All right. So, we are getting to the end of clinical methods. So, examination of the nervous system. So, this should be the last topic, but I have divided it up into 3 parts. I divided it up into 3 parts. So we will have the examination, history and examination. Then we will also have the cranial nerve examination and then the examination of the motor system. Okay. So today we will start with the introduction to examination of the central nervous system. Okay. So it starts with the history, and a thorough neurologic history is important because it allows you to decide which part of the physical examination you should concentrate on the most. It also helps you to understand where the etiology is or the pathologic diagnosis of the patient. But it's very important for you to have a basic principle of the basic disease processes of the central nervous system, because you only see what you know. So if you don't know that walking in a particular way is a sign of cerebellar disease, you will see it, but it will not make sense to you, even though you've examined the patient. So a good knowledge is also very important. The history should include, so history starts from the presenting complaint. And the history of the presenting complaint should include the symptom onset. So was it an acute onset? Let's say headache, for example. Was it a sudden onset of headache? Was it subacute? Was it chronic or insidious? All of these indicate different things when you are looking at headache. So a sudden headache, for example, thunderclap headache at the back of the head can indicate something like a subarachnoid hemorrhage. But if it is of chronic onset, then you can think of maybe like a brain tumor. For example, if it is subacute, it can indicate maybe tuberculous meningitis. If it is acute, it can also indicate meningitis. So the same symptom of headache, depending on whether it's acute, subacute, chronic, or insidious, it gives you a certain diagnosis. The duration is also important. A sudden onset of headache or a day's duration associated with seizures and fever could indicate meningitis. But headache of maybe a month's duration, which is chronic, can indicate a brain tumor, for example. Then the cause of the condition is also important. As it remains the same, so is it static? Or is it getting worse? That is progressive. Or is it relapsing and remitting? So it comes and goes. Then any associated symptoms with that particular symptom. So something like, is there any pain, headache, nausea, vomiting, vertigo, numbness, weakness, and seizures? All these associated symptoms will help you piece together and know what is wrong with the patient. Now, it's also important for you to find out what the patient has done about it, any previous diagnosis, any previous therapeutic intervention. So maybe they did a CT scan, what did the CT scan show, and all that. So a complete history usually allows you to define the problem, to know the cause of the problem, and then gives you an idea where to focus on when you are doing the neurologic examination. The neurologic examination is very wide, and that's why it's important to take a good history so that you can decide on where to concentrate on. Otherwise, if you want to do a full neurologic examination, it can take you anything between 45 minutes to 1 hour to complete just a neurological exam. So it's important for you to focus your history so that you can also focus your examination. Now, we'll look at a few common symptoms. We are not going to look at all the symptoms and the nervous system, just the common ones. So headache is one of the commonest neurological symptoms. It can either be primary or it can be secondary, meaning that it is due to something, an underlying cause. And it's can also occur in neurological conditions as well. Whenever you have headache, you have to explore the Socrates, the site of the headache, because it's a kind of pain. The site of the headache, the onset, the character, radiation, associated factors, relieving factors, timing, and severity. Okay. How does the patient feel in between attacks? So these are a few differential diagnoses when a patient presents with headache. Like I said, if it's acute, it can be a subarachnoid hemorrhage, meningitis, certain medications, or glaucoma. If it is acute and recurrent, then migraine should be on your list of differentials. Cluster headache, neuralgias, glaucoma as well, and then sinusitis. If it is subacute, then you'll be thinking of the infections, anything that increases the pressure in the brain, like a tumor, or inflammation of the arteries around the temporal area. If it is chronic, then there's something called chronic daily headache syndrome. It can also be as a result of depression or some medications. Okay. So that is for headache. Now, if a patient presents with disturbance of consciousness, that is altered consciousness or loss of consciousness, usually then the patient will be brought in by relatives. And so the patient might have difficulty. Some of the terms they might use might maybe blackout, faint, dizzy spells, funny terms. You need to establish exactly what happened, how it happened, if there were any warning signs, how long did it last, did the patient recover, what happened after recovery. All these are very important. I remember last semester, one of the groups presented on seizures, and these parts of the history are very important for you to distinguish between a seizure and syncope. Okay. Now, you need to sometimes ask the patient to act out, the eyewitness, to act exactly what was happening. If there were seizures, maybe they would be jerking their hand for you to see exactly how the patient was, how their breathing was, and all that. Okay. So let's look at vertigo. Vertigo is the sensation of rotatory movement. So it's an illusion of movement. And usually it gives a certain impression. When somebody complains of vertigo, you want to find out if there's imbalance or if it is due to a central cause, something that's going on in the brain. And for the central causes, migraine, brainstem ischemia, multiple sclerosis. If it is peripheral, that means it is limited to the ear. So even medications like gentamicin, which are ototoxic, can cause vertigo. So your past medical history. So I just dwelt on the commonest symptoms that the patients can come to you. But the symptoms are a lot. Loss of vision, blurred vision, difficulty walking, unsteady gait, weakness, several of them. But for each of them, we follow the same pattern of exploring the symptoms very well. Please mute your microphones. Please mute your microphones. Okay. So the past medical history, you would look at any previous neurological symptoms that the patient might have had. Sometimes it might be important to go into the childhood history. Is there a history of epilepsy in childhood? Is there any associated symptom? Is there hypertension, for example, any other vascular disease? Okay. Then drug history. When we were going through the symptoms, you realize that some symptoms are associated with certain medications, like gentamicin causing vertigo. So your drug history is very, very important. These are a few medications which are associated with certain symptoms. So ataxia is unsteady gait and can be associated with anticonvulsants like phenytoin, carbamazepine, and benzodiazepines. Then cyclosporin is an immunosuppressive drug. Fluorouracil is an anti-cancer drug. Dizziness can be associated with aspirin, common aspirin, or antihistamines. So if you have a very bad cold and you are taking Rising, it can cause you to have dizziness. So drug history, very, very important. Headaches. You realize that statins are there. They are anti-cholesterol medications. Glycerol nitrate is used for people with myocardial infarction or heart attacks. Then sildenafil is a famous Viagra. So if a patient is on Viagra and they are complaining of headaches, that could be the cause. Okay. Then other medications can cause memory impairment, so memory lapses. So benzodiazepines, corticosteroids, chlorpromazine, isoniazid. Isoniazid is one of the medications used in the treatment of TB. Family history is also important because a lot of neurological conditions are genetic. So, for example, cerebellar illnesses, Huntington's disease, Alzheimer's, migraine, they all have a genetic component. So it's important to find out if anybody in the family has any of these. And social history cannot be overemphasized. Alcohol is a very common cause of seizures, cognitive impairment, neuropathy. Poor diet can make this worse. Other medications, usually recreational drugs, so cocaine, ecstasy, they can cause seizures. Then smoking can also these same cocaine and ecstasy can also cause seizures and strokes. So it's important to find out these things from the history. And sexual history is also important. A disease like HIV can have some neurological manifestations. Syphilis too, but it is sexually transmitted and it's associated with multiple sexual partners, risky sexual behavior. So you'd want to find these out from the history. It's also important to try and find out the level of impairment of the patient's daily activities. So how is the patient able to cope with their daily activities? Do they drive, for example? Do they have any problems with coping? Do they have support systems and so on? Sometimes you would want to find out about things like fear, anxiety, depression. Okay, so once you've taken a good history, then you come to a focused neurologic examination. The neurologic examination is done to localize the problem or the lesion, whether it's in the central nervous system or the peripheral nervous system. And usually, this takes a very long time, between 45 minutes to 1 hour. But once you take a good history, the physical examination can be very rewarding for you. Okay. So these are the steps in the neurologic examination. There's examination of higher mental function, then examination of the cranial nerves, examination of the sensory system, examination of the motor system, examination of the cerebellum, and examination of the meninges. Okay. And these are the instruments that you need for central nervous system examination. You need an ophthalmoscope, a reflex hammer, a tuning fork, and then safety pin, which is used for testing sensation. So let's move to the examination of higher mental function. So higher mental functions include gait, speech, and mental status. So when you look at the gait is the attitude of the person in the upright position. That is, how is a person positioned when they are upright? And some of the abnormal types are hemiparetic gait, ataxic gait, shuffling gait, steppage gait, spastic or Caesar gait, and an arthralgic gait. So a hemiparetic gait usually occurs in a patient who has had a stroke. before. And usually you see that the hand may be clenched, the knee will be held in extension, and then the ankle is plantar flexed. That is, it is pointing downwards. And when the patient is walking, they have to circumduct the affected leg. Like they move the affected leg in a semicircular motion before they can move forward. Ataxic gait is a broad-based gait. So when the patient is walking, they walk with their two legs apart. And this is because they have an imbalance. So they try to steady themselves by opening the legs wide so that they can support themselves. So sometimes when it's very severe, you see that the patient will stagger as they walk. And when the patient has an ataxic gait, it indicates that there's a problem in the cerebellum. Okay. Shuffling gait is usually found in Parkinson's. And it's just like the name suggests, the patient walks with shuffling gait, as in they drag their legs. What we say, yes, that's a shuffling gait. High steppage gait or slapping gait is usually caused by foot drop, which is caused by paralysis of the nerves that supply the muscles of the ankle and then the leg. So you realize that the patient naturally, when they lift their leg, the foot drops. And so they have to lift the leg very high to prevent the foot from dropping. And then when they take a step forward, they bring the foot down and then it slaps against the floor. So that's what we call the high stepping or a slapping gait. And usually that indicates paralysis of the common peroneal nerve, which supplies the muscles of the ankle and then the leg. Okay. Spastic or seizure gait usually occurs in patients with cerebral palsy. There's increased tone, or they are held together in adduction. So they are closer to their bodies and the body, and it's difficult for you to draw them apart. Usually you find this in patients with cerebral palsy. Arthralgic gait usually occurs when the patient has a painful lower extremity. So maybe pain at the hip from a condition that maybe has caused some inflammation there. Arthritis at the hip, avascular necrosis of the hip, and so on. And usually you realize that the patient puts the hand over the affected side and tries to balance their weight, shifting it from the painful side to the non-painful side. So when they walk, you realize that there's a dip, and then they come back, and there's a dip, and then they come back. So that's arthralgic gait. So all these things about the gait can give you an idea of what is wrong with the patient just by looking at how they walk into your consulting room. Another assessment of higher mental function is the speech. And speech abnormalities include dysphonia, dysarthria, and then dysphasia. We'll look at each of them in detail. When we say a patient has dysphonia or aphonia, it means that they are unable to produce the sound, or they have an inability to phonate. And as a result of this, there's hoarseness of the voice. This usually means that there's a problem with the voice box or the larynx, and the commonest cause is the common cold. Other causes are hypothyroidism or amyloidosis. Neurologically, if there's a paralysis of the nerve supplying the vocal cord, which is called the recurrent laryngeal nerve, you can have dysphonia. Or if there are problems with the vagus nerve, which is a cranial nerve, you can also have dysphonia or aphonia. So dysphonia means that the voice is not sounding well, and aphonia or dysphonia means the voice is abnormal. Aphonia means the voice is gone. Then we also have dysarthria or anathria. So dysarthria is the inability to articulate spoken words. So this patient is not able to say exactly what they mean. So, for example, the words can be slurred, but the patient understands what you are saying all right. And this usually occurs from paralysis of the muscles that help in speaking. So, example is paralysis of the pharyngeal nerve, the palate, the lingual, or the facial musculature. And then also when you have cerebellar disease, you can also have this. Okay. Another sign of cerebellar disease is ataxia, which we looked at previously when we were talking about the games. Okay. So another disorder of speech is dysphasia. And dysphasia is the ability, is the inability for the person to process language. Please mute your microphones when you are having the lecture so that we can all.
Benjamin, Adam.
So, this is impaired language ability, and there are two types. Either the patient is not able to understand the language, that is receptive or sensory aphasia. And then you can also have inability to actually speak, that is expressive aphasia. Okay. And when you have the two, that is patient cannot understand and patient cannot speak, then it's a global aphasia. And this is the part of the brain which controls the speech. So we have the Broca's area, where it controls the articulation or the expression of the speech. Then we have the Wernicke's area, which controls the reception or the understanding of the speech. The central sulcus connects the two, so that when you have signals from the Wernicke's area, it is transmitted to the Broca's area and you're able to speak to and reply to whatever you've heard. So when there's a problem with the connection, you realize that what the patient is saying is not the answer to what you are saying. So it means that the patient's understanding and the speech are disconnected. Examination of the higher mental status is a mental status exam. The mental status exam looks at the patient's memory, their orientation, and their intelligence, as well as other aspects of their psyche. So looking at the memory, you can test the patient's memory by asking them to keep certain numbers in order. Maybe you say 1, 5, 7, and 8. And then you tell the patient, keep these things in mind. Then you ask the patient a few things in your history, or you do other things. Then you come back and ask the patient, can you remember the things that I asked you to recall? Okay. So usually if you have chronic dementia, the patient remembers the things that happened a long time ago, and they cannot remember current things. So remote memory is preserved. You can realize that the patient has a very short attention span. Okay. Then orientation is also another test of mental status. So orientation is the patient's sense of their time, place,
Evans,
and
please
person.
mute your microphone. You're giving us feedback.
You are there mentioning people's names.
Time, place, and person. So, for example, you ask the patient, who are you? Then maybe the patient is a male, but says that I am Amma. Or you ask the patient, where are you? And then the patient says, I'm in school. Meanwhile, they are in hospital. And then you ask the patient what time of day it is. Then they will tell you it is night. Meanwhile, it is morning. Okay, so you try to test the patient's orientation in time, place, and person. Note the order. So you see, the order is patient status in time, then place, then person. The functions are affected in the same order in organic disease. But if the orientation is different, the order is different, then it tells you that this patient has a psychiatric problem. Okay, so what exactly do I mean? For example, you lose the sense of time, and then you lose a sense of place, and then you lose a sense of person. That's the last thing to be lost. But in a patient who has lost a sense of person but has an intact sense of time, may be having a psychiatric problem. I hope you understand. So when the patient has an organic brain problem, then these functions are lost in the order in which they appear. So time is lost, then place is lost, then person is lost. Okay. And usually the sense of person is the last to be lost. Okay. Yes, so like I said, the order may be disturbed in psychological dysfunction. So a patient who does not know who he or she is, but at the same time is well oriented in place, is more likely to have a psychological problem than an organic etiology for his condition. Okay. Then you also test the patient's intelligence, and this involves how the patient is able to successfully maneuver themselves from a new situation. So problem solving, their vocabulary, the fund of knowledge, what they know about certain subjects, calculations, abstracts, things, their judgment. So for example, if you find a wallet on the floor, what are you going to do with it? And so on. Oh, I think I should have said thank you or summary before I just ended like that. Sorry. There's a joke about a patient who, a journalist who went to a mental home and then asked the doctor, so doctor, how do you know that the people are mad before you admit them? And then he was like, oh, he would just ask them a simple question. You have a bad tap, and then you ask them that, what's the easiest way to drain water out of the tap? Will you use a spoon, a cup, or a bucket? Then the journalist said, oh, but that's simple, you use a bucket. And then he was like, oh, then you yourself, you have a problem, because the easiest way is just to release the drain and then you let the water out. So each of us has a small thing somewhere, but we are keeping it together. The day that you lose all, then that's when you have issues. Yeah, so please, are there any questions? Esther, please ask your question. Esther.
Okay, madam.
She's with the kid.
Where's Esther? I thought she raised her hand. Okay, you go on.
Please, can you hear me?
Yes, I can hear you.
Okay. And please, my question is on the headache.
Yes.
Can change of environment bring about those headaches? Because I have an elderly relative. She changed environment in December. I was called that she said she can't sleep. She's been having burning sensation in the head. They've taken her for a CT scan, and then they said they can see small brain aneurysm, but they think that cannot cause what she is saying. And so I wanted to find out, can change of environment, or is there already and we didn't know?
Okay, you were saying that she's unable to sleep. I think that would be more a likely cause of a headache than the aneurysm or the change of environment. So it might be likely to her inability to sleep. That's what might cause the headache.
So that means they have to do more tests, right?
No, if she's unable to sleep, what other tests are you going to do?
I was thinking that just last week she went to see the doctor and they monitored her BP for a week, and then they said her BP ranges between 148, 84 their way, but one of them it shoots to about 160 and then it came down again.
Okay, so hypertension can also cause headaches.
Pardon, doctor, I didn't hear that.
Hypertension can also give you a headache.
Okay. Okay.
How old is she?
She's 70.
Yeah, so that blood pressure is high for her age.
Mm,
Any blood pressure above 140, 90 is high. And as you grow older, you need a lower blood pressure. So the older you are, the worse you react to changes in high blood pressure.
okay.
Yeah.
Okay, thank you.
All right. Any other questions?
Okay, madam, my question was on the difficulties speaking. And you said something like dysphonia, unable to produce sound.
Yes.
In one way or the other, like we've all experienced that before. Like you wake up in the morning and then you realize that your voice is gone.
Uh-huh.
So with that one, do you need do you need to go through this examination to find out what is wrong, or it will just go because sometimes it just resolves on its own?
So you remember I was saying that the commonest cause is a common cold. And so if it is something that resolves on its own, then you may not even need to go to the hospital. If it's gone, there's no point going.
Okay, like, but I'm saying that let's say the patient has come to your consulting room and then is experiencing this. So like, will you do further checks, or because it normally resolves on its own?
No, so you see, any condition at all can be normal or abnormal. So you have to put it in context of history and physical examination. If the patient tells you that this thing has been happening to them, or if the patient says that there's something else wrong, like they have headaches or they have blurred vision, then you can't just leave it alone. You have to investigate further. So it all has to do with what you find from your history and physical examination. That's what will help you decide whether to just ignore or to go further and investigate.
Okay, thank you.
Okay. Any more questions? Yes, please ask your questions. Don't worry about raising your hand. You can just go ahead and ask your questions.
Madam.
Yes.
Please, what is the correlation between alcoholism and vertigo? If chronic alcoholism, if someone is an alcoholic,
correlation a bit more. Are you working with
vertigo in any way?
Yeah, so I was saying that, you see, vertigo has and peripheral causes. The peripheral causes means that it is coming from the ear, and the central causes means that it's coming from the central nervous system. So when you take in alcohol, you get intoxicated. It impairs your cognition and then your ability to process things. And so that can give you the vertigo. Vertigo is the illusion of motion. You have the feeling like everything is going round, which is an effect of alcohol causing CNS impairment when you take it in large amounts. Are you okay?
Yes, madam, I'm fine. Thank you.
All right. There was another question.
Yes, madam, please, I want to ask a question. Is there any physiology associated with excessive crying and dysphonia? Because there's instances where you meet somebody who cries a lot, like for a considerable number of hours, the person loses the voice. Is there any physiology associated with it?
The voice box is the larynx, okay? When you overuse it, you can get inflammation. So people who use their voice a lot, like teachers, like preachers, like people, like you're saying, people who cry, they can have inflammation of the larynx or laryngitis, and that can lead to hoarseness of the voice. Are you okay?
Yes, mom, I'm okay.
You ask a question, they asking, are you okay? Are they?
Oh, Nat.
Yeah.
Madam, please, concerning the same loss of voice. So what of this? I want to also know the physiology behind
men who are in a room with a different girl and maybe their wife friend or their girlfriends pounce on them, then they get dysphonia. That one, what is the physiology behind?
I speaking from experience. I speaking from experience.
I thought as much.
That is more psychological. So we have something we call selective mutism, which can occur in a situation of emotional shock. So, as an example, in pediatrics, maybe a girl has been sexually assaulted by an uncle or somebody in the household. You'd realize that when the person is in the vicinity of the said individual, they are unable to speak. And so that's selective mutism. And so in this case, it could be an example of that, where it is more emotional or psychological rather than physiological.
Okay, madam. Thank you, madam.
All right.
Madam, I think that one, it is fearo issue that is happening, because if the fear grabs the person,
Not a drone chill the home. Not a drone chill the home.
A drone, you ever to another one or my man too.
A drone chill.
It's still psychological. Any other questions? Any other questions?
Madam, my question is, with the loss of voice, can it also be, let me say, change in hormones or hormone activities? Can it be another cause of it?
You remember among the causes, we mentioned hypothyroidism.
Yeah.
Yes, so it's a hormone. So yes, it can affect the voice.
And madam, how would you know if it's the hormone that's causing it, or it's a psychological issue?
It's your history. It's your history. It's your history that will tell you.
Okay.
So, of course, if it's psychological, it means there are antecedent events which cause psychological trauma. And so once you take the history, you will find out that that is what it is.
Okay.
Yeah.
Madam, please, the inability to process language.
Mm-hmm. You can't hear your question. You have less than a minute.
I said the inability to process language.
Yes.
Is it the language that previously the patient knew, or let's say a common language? Okay.
No, of course. If I don't understand a way, I would never be able to process it when I'm sick. Do you understand? So it is what the patient knew already and is now unable to understand.
Okay.
Yeah.
Madam,
Any other?
Madam, so those who are able to speak in tongues.
Me too, I beg.
Hey.